how might healthcare best be delivered to the elderly? One of my guests today, Dr. Marilyn Gugliucci, would hardly claim to have any easy answers to that question. There probably are none to be had, but she is exploring ways by which these matters can be handled sensitively. She administers 2 programs, the University of New England College of Osteopathic Medicine, that are designed to help students better understand how patients feel. Marilyn, welcome to the show.
Thank you very much, Harriet. It's great to be here.
How are things doing up in Maine?
It is a beautiful fall day today. It's
oh, wow.
Picture perfect.
I'm sure. And now, tell us, describe how the Learning by Living project, how does that function?
Sure thing. And if I can bring you back to how it even came about. And
go ahead.
What happened. So I'm a professor and director of geriatrics education and research at our College of Osteopathic Medicine. I do lectures in the medical school, like any faculty would. And I finished a lecture with the first-year medical students, and this happened to be back in 2006. And at the end of that lecture, and I tend to make those really kind of outlandish, crazy, passionate, just to get student attention about aging because our society is so fearful of it. I had a student come up to me after the lecture. They call me Dr. G, and she said, Dr. G, I want to learn how to speak with institutionalized elders, quote, unquote. What went through my mind first was I never use that term institutionalized because it connotes prison, insane asylum. It has very negative connotations in this field. And the other thing I thought about, Harriet, was you would speak to an older adult in a nursing home as you would any person, any adult. And I knew that that answer was not going to move this student, that she wasn't going to get it. And I'm not sure where it came from, but this happens to me all the time. I asked the student, would you live in a nursing home for 2 weeks as if you were an elder resident? There was a pregnant pause. And we looked at each other for 30 seconds, and all of a sudden she said, I would. Now, I had no idea if I could place a student in a nursing home for 2 weeks with a diagnosis. Turns out a good friend of mine in Skowhegan, Maine, who ran a for-profit nursing home, went to his board, and they approved the project. There is no money that changes hands in this project, Harriet. So nursing homes right now, I'm in 4 states. New York, they'll lose somewhere around $500-600 a day. In Maine, they'll lose about $350 a day by having a student live there. Now, what happens is the student goes in as a resident with a diagnosis, and they get standard procedures of care. I give them a diagnosis of stroke and pneumonia secondary to aspiration. What that means is that they need to be on pureed foods for a few days. They need to be in a wheelchair. I take away their dominant side. They live in a room with a roommate. Many of them have a roommate who probably is in their 80s or 90s with dementia. Some students have actually been in what some nursing homes call a lockdown unit, which is a unit or a floor dedicated to people with dementia, and they lock the doors for safety so that people don't wander. So these students are behind locked doors. Now, the interesting part about this project is, and it is based on research, but the interesting part of this project is at the end, the student doesn't want to leave. They connect heart to heart with the people that they're living with. They experience everything that a physician would write orders for. And yet, that human connection, that sense of community, is what rises above all the challenges that they face, and they have trouble leaving the home.
That's fascinating, because you would think that other than prison would be the one place people want to leave.
That's right. And I can't tell you how many people talk with me about this project, and they say, well, how many students have you lost in the program? You know, how many have left the home halfway through? Every student has stayed to the end. And actually, I had 2 students in 2 different nursing homes this past summer in 2 different states. And one student, I said to him, we do a debriefing at the end. We did it a day earlier because of the CEO schedule. And I said, usually students are discharged after the debriefing. Do you want to leave today or you want to wait until your normal discharge? And he said, I can't leave today. I can't leave yet. So I will stay till the end.
Wow.
Yeah.
That's pretty strong.
It's very, very, can you imagine being toileted, being bathed, eating pureed foods, being in a wheelchair, not using your dominant side? All the students are ambidextrous by the end because they start using their non-dominant hands so much.
Sure.
They learn how to knit one-handed, how to shave, how to brush their teeth.
How to knit one-handed.
Yeah.
That's pretty impressive.
It is, and this is something that I've presented on. I just came back from Germany last week for an invited presentation on this program. I've been in Ireland twice, Italy twice, Norway, heading to Finland, and at this point I think we are the only medical school in the world admitting medical students into nursing homes to live the life of an elder resident for an extended period. And the remarkable part is, and I mentioned it before, no money changes hands.
Wow. Wow.
The homes that take these students are the homes that are really interested in getting feedback. The students have to write a journal, and we do a debriefing with the home. We talk with the staff, with the residents, and the CEO, the administrators get a copy of the journal.
Mm-hmm. Now, describe the Hospice Home Immersion project.
Sure. So I mentioned that it's Learning by Living Nursing Home Immersion. That project is based on research and is actually called a qualitative ethnographic research. It's based on anthropology. So people live in an environment. They are not supposed to alter the environment, and they learn about the environment from being immersed. So that was the methodology that I applied to the nursing home immersion. I took that same process, those same methods, and I applied that to hospice home immersion. We have an 18-bed inpatient hospice home about a half hour away from our school. I was actually part of all that designing way back. That home has been there for 10 years. Well, I went up to the administrators and said, would you consider me immersing pairs of second-year medical students to live there for 48 hours? Now, in this case, we couldn't have the students be patients because at end-of-life care, it's just a very different thing. There's no activities. People usually stay in their rooms for the most part. And I needed to find a way to get students integrated into how to work with people who are in the dying process, how to work with their families, how to work with an interprofessional staff team. So the students actually provide care. They provide patient care, family support, post-mortem care, and they sleep in a bed where other people have died before. So it's an incredible immersion. The students come out totally exhausted at the end because many of them are up until 3, 4 in the morning and then up again at 6 a.m. And the change in these students from the time that they go in, and you can imagine how nervous and anxious they are going into the home, wondering if they're going to be appropriate, if they're going to be able to manage their emotions. And then when I pick them up on Sunday, or 2 days later, 48 hours later, they are so excited, so engaged, understand that dying is a part of living, understanding dynamics within families, and truly engaging in an interprofessional environment where a chaplain, a social worker, the nurses, the certified nursing assistants, the doctor are all working together to provide good patient care. And the medical students come out and they say, why are we not treating all patients this way?
Now, are the students who are part of these programs they volunteer, or is this a requirement for their graduation?
And there is no requirement. All the students that do either the hospice home immersion or the nursing home immersion, it is purely volunteer.
Wow.
So especially for nursing home immersion, think about taking 2 weeks of your summer vacation when you only have about 6 weeks vacation during medical school and living that in the nursing home.
You have to be pretty dedicated.
Exactly. And these students, most people say, well, these students are all interested in being geriatricians, providing care to older adults. And the truth of the matter is the first student was OBGYN. Many of the students might be primary care, emergency medicine. They just want to learn how to be really good doctors. And they feel that by doing this project, that will help them to do that.
Okay. Now, from what you are saying, and I believe you because it sounds like a powerful experience, these students are very touched by what they see, smell, hear, feel, all senses coming into play.
Yes.
Very touched. Do you think, other than being touched, this is something that affects the way they will practice medicine?
There's no question about that. Absolutely no question for me whatsoever. I have done longitudinal data collection from, meaning that, the first student that went in 2006, actually I just got more information from her not too long ago, following up on these students to say, has this project been meaningful enough to you that you've remembered it and that you have changed the way you work with your patients? And in all cases, there are some key outcomes from this. One is they use touch more. They like to touch the person. They like to be at eye level, voice cadence. I mean, these students know what it's like to be sitting in a wheelchair, having somebody pull you in reverse, not even knowing where you're going, being in a strange environment. And they understand that feeling. So now, when they are in hospitals or working with their patients, they are very aware of how important it is to be at eye level, to sit next to someone, to put a hand on their arm or hold their hand, depending, what's appropriate, and slow down and just really talk in a very human way. So I think there's a level of compassion that has come through this. Now my goal in life, Harriet, is to change the world regarding creating more positive feelings about aging and being older. And I really think I'm accomplishing that. It may be one person at a time, but if I can get one student to feel more comfortable about working with someone who is at the end of life, or have students feel more comfortable working with people with dementia or people who are in a nursing home for whatever reason, then I've accomplished my goal. And I feel confident that I've done that and continue to do it.
Are saying reminds me of book, the late Dr. David McCullough, My Mother, Your Mother.
Yes.
He talks in there very much about touch, slow medicine.
Yes. And I know David McCullough, and he's presented at our geriatrics conference, and he was just a remarkable man.
Yes, he was. I spoke with him. Now, okay, we're going to have to ask some ticklish questions here, but that's okay.
I'm sitting down. It's all right.
You're sitting down? Well,
yes.
Okay, and you said you had a beautiful day, so you're relaxed to it. What you are talking about is beautiful. More touch, more human connection, particularly for people who may not be in a position to benefit a great deal from technology. Wonderful. But if that is the way these students seek to practice medicine, doesn't that put them a bit out of sync with what is happening?
Well, that is a very interesting question, actually. Now, in osteopathic medicine, in that field, which is different than, so an osteopathic physician comes out with a DO. An allopathic physician is an MD. They both go through very similar trainings. The osteopathic physician does have another tool in their toolkit in terms of doing what's called osteopathic manipulative medicine, which is a touch kind of helping the body heal itself, align itself. It's not chiropractic, but the biggest difference is the philosophy of an osteopath. And that, I think, comes into play here, Harriet, that we are training our students to look at the whole person, the entire person. And what I mean by that is that how many people have had back injuries, let's say, they go to a physician, whatever kind of physician, and the physician says, oh, you have a bulging disc or you have tight muscle or whatever they might say, and here are some muscle relaxants for it. Now, what we hope will happen with an osteopathic physician is that physician will say, tell me the story about how this happened. Tell me about, how it is that you move. What is it that you do for work? What has this injury done to the way you live your life? So that they are moving away from the injury itself to find out more information about what is happening in that person's life, which then helps them determine how better to treat it so that the person can then get back to being as fully functioning as they possibly can. That is a very different way to approach medicine, and most people who see an osteopathic physician, if they have a good physician, that physician will look at life context in relation to whatever's going on in their body. And that is congruent. So regardless of whether you have electronic medical records or not, knowing who your patient is, I think, is the first step to being a good physician.
Now, will they practice in special osteopathic hospitals?
Actually, everything is being combined. Allopathic, osteopathic, hospitals will have both. I bet most people probably don't even know whether they have an allopathic or an osteopathic physician. You would not be able to tell by looking at them. You might be able to tell by the initials behind their name or the way they practice medicine, possibly.
Now, what are some of the suggestions your students have arrived at? In other words, they are being led to understand how does a patient feel. What are some of the ideas they've arrived at that possibly could be put into force?
Well, I can give you some concrete examples. When I had a student in a nursing home, the staff started running in to the administrator saying, oh my goodness, this is a 25-year-old person. Shouldn't we put a TV in the room for the student? And the administrator would say, do we have TVs in all of our patients' rooms, in the residents' rooms? And the staff was like, no. And then, this student is here to be a resident. Do we want to treat that student differently than we treat all our other residents? And what it did was just raise the consciousness around what is it that they're providing for their older residents. Why should it be any different because the student is there and, the student's in their 20s or early 30s? There was one particular student who was in the Navy and actually lived in a Maine veterans home. Now, the staff got the student, wheeled him in his wheelchair into the dining room, put the student at a table in the corner of the room facing the corner. That student felt so uncomfortable. The student wanted to be facing the room, wanted to see the people, wanted to observe, hopefully engage. And when we brought that to the staff's attention, they were mortified. They said, oh my goodness, we did that so that the student wouldn't feel overwhelmed by the environment. That we were thinking that we were, confining the space so that the student wouldn't be overwhelmed and could manage during the first meal.
Okay.
And the truth of the matter was that created a lot of anxiety for that student to not be able to look around. So now, that staff asks people, where would you like to sit today? That is just a very simple thing that could take away a whole lot of anxiety. Another home actually started family orientations. The student was hanging out with her friends, and the hangout spot was right by the elevator. They all just hung out there, watching who came off the elevator, where they went. What the student noticed was that family members would come off the elevator and they would avert their eyes, making the student feel really insignificant. And, the family wouldn't acknowledge, wouldn't say hello. And the student mentioned this to the staff, and the staff then implemented a program, an orientation program for families saying, please use eye contact, say hello, engage with the residents on any of the floors. So those are some minor examples, but it's amazing what these students realize. Something about as simple as being wheeled down the hallway. How many times if there's something on the wall, you just want to stop and take a look at it? But if somebody's wheeling you, you can't do that. And the student was just totally frustrated by not being able to see the artwork. So it's very subtle in some cases, and yet it is incredibly significant to the person who's living there.
I understand, and I can see how these things would be significant, but there's one factor. I don't know about the nursing homes where these programs have taken place, but in an awful lot of nursing homes, there is an intense shortage of nursing aides or nursing assistants who might be the people who are dealing with some of these things. If there are usually 2-3 people on the ward, on a ward in the nursing home, and one person calls in, so there's only 2, or maybe there's only 1. How do they have time to deal with some of these things?
Yeah, it's an excellent question. Now, I can't speak about all nursing homes, but I can say for the nursing homes that have taken our students, they are interested in culture change. They wanted to have a student in there and have that inside-out look and get feedback about that. Now, one of the things I'm always concerned about is that I know how hard the certified nursing assistants, the CNAs work, and the nurses, and then to have a student underfoot that is requiring, toileting, being transferred from the bed to the chair, and this is all staff time. And I was just really concerned about that. And in every case in the homes that my students have been in, and again, I mentioned 4 different states, about, 18 different homes, the administrators and the staff said, no, we want to do this. We want to treat this person just like all of our other residents. And I think the piece that many people miss about nursing homes, and the nursing homes that, what do I want to say? The nursing homes that are working, I don't know if that's the right word, but it's because they're paying attention to the people in the home, not only the residents, but we have found in Maine that, yes, there's no question that certified nursing assistants are getting paid a low wage, and that makes it difficult for them. The bottom line is, though, if they feel appreciated, if they are treated with respect, and they're given opportunities to improve their skills, that means more to them in many ways in terms of job satisfaction and the work that they do than giving them a higher salary. So just having a higher salary but not being respected is not going to make things better in nursing homes. Honoring our CNAs will.
It would be very interesting to see how retention of nursing assistants is in homes that initiate some of the programs you suggested, some of the ideas you suggested, and in other homes. If, in fact, it has led to greater job satisfaction and retention.
And I think, one of the things that's kind of interesting is in one of our, we have a series of homes here, they have what's called a CNA 2-3 program, that you come in as a CNA, and then after so much time and doing so many things, maybe education sessions, you become a CNA 2. The CNA 2 is the person who's responsible for the CNA 1. And then you become a CNA 3. So you're kind of moving up that ladder, and you're teaching and mentoring the other CNAs. Now, those CNAs that are working to climb the ladder feel so much better about themselves and the job that they're doing. And in that particular home, I just completed an oral health research project, and those CNAs, when we talked about taking them off the floor to do education on oral health, they said, we don't want to be away from our residents. We are responsible for their care. The pride in this home that these CNAs had for their residents is remarkable. That's the kind of atmosphere and culture that you want to create. And ironically, Harriet, in this program, what I found out, I can't tell you how many nursing homes I'm in and how many older adults I have assisted through nursing home care, that the sense of community in a nursing home, in all the nursing homes I've been in, is very strong. And the question is, are people opening their eyes and opening their hearts to see this? So I have had faculty from other schools say, oh my God, Learning by Living is such a great project. I'm going to put all my students in a nursing home. I was like, please do not do that. Don't. If you put a student into a nursing home for a few hours, for a day, 24 hours, that student is going to come out with very negative feelings about older adults and negative feelings about nursing homes. You are going to solidify everything that our society says about these environments. But have our students in there over a long period of time, have them immersed, and they become part of the community and understand the beauty of the community. And
Marilyn,
this has happened in every case.
Thank you very much for being my guest. And if you tell our listeners where they can get more information about some of the programs you discussed.
Yes, they can either just look up my name, and there'll be information on the Learning by Living program there, and the Hospice Home Immersion. There's publications on these. But I think most of them are probably associated with my name, and I do have a website at the university. So I think just plugging in my name might be the best way to do that.
Thank you very much.
You're very welcome. Thank you for this opportunity.
You have been listening to Aging Without Wrinkles on the Artist First Radio Network. All past broadcasts are archived. You can pick them up at artistfirst.com. Thank you, and we'll see you next time on Aging Without Wrinkles on the Artist First Radio Network.